Hi, I'm Dr. Stan Steindl. Welcome to Compassion in a T-shirt. Today we'll be talking about compassion and self-compassion in the context of chronic health conditions. Today I'll be speaking with Dr. Inês Trindade, who is at Örebro University in Sweden. She's an accomplished and widely respected researcher in compassion and self-compassion, acceptance and commitment therapy, and health psychology. In particular, she focuses her work on inflammatory bowel diseases and the way that these conditions can affect psychological outcomes. A recent 2021 paper shows that self-compassion can predict lower depression, anxiety, and stress in people with IBD. She's run some exciting trials looking at face-to-face and online interventions, incorporating compassion-focused approaches and acceptance and commitment therapy approaches, and with some encouraging results. It was a pleasure to speak with Inês and to hear her talk so compassionately about her work and the people she's serving. And so I bring you Dr. Inês Trindade. Dr. Inês Trindade, welcome to Compassion in a T-shirt.
Thank you very much for having me. It's such a pleasure to be here.
It's exciting to get to speak with you again after several years. But yeah, you've done some incredible research, and I remember years ago, your PhD and all of the really valuable research that came out of that and the stuff you've been doing more recently. I'm keen to really dive into some of the research, but I wondered before we do that, if you could just help us understand a little more about inflammatory bowel disease and bowel-related disorders, what they are, how they affect people, why it matters really to do some of the work that you've been doing.
Yeah, sure. So IBD goes for inflammatory bowel diseases, and these are immune-mediated disorders of the GI tract. And these diseases are comprised by two main forms of IBD, Crohn's disease or CD, and ulcerative colitis or C. And so Crohn's disease affects any part of the GI tract, while UC only affects the colon and the rectum. So they have quite similar symptoms, but they are different conditions, sometimes with quite different approaches in terms of medical treatment. These conditions affect quality of life and mental health of patients quite a lot, especially during active disease phases where inflammation is higher and the condition is active. And so therefore, in those periods, patients show quite a lot of symptoms, very painful symptoms, impairing, and they are not able to lead a normal functional life during that period. But even in periods of remission, so when disease is not active, even in those periods, patients do present lower quality of life and higher psychological distress than people from the general population. So these diseases are quite impactful even when patients do not show symptoms and or do not show a clinical activation of the disease. And we also have other types of GI conditions that are very common, which are called DGBI or disorders of gut-brain interaction, in which we include IBS or irritable bowel syndrome. And in these conditions, there are no obvious structural or biochemical changes. And I say obvious, and that's a very important word because sometimes we describe DGBI as a group of disorders with symptoms that are not explained medically, which can be quite dualistic if you think about it, and also quite stigmatizing because as far as we know right now in science, nothing that happens in our bodies can actually not be explained by something physical, right? So we do know that there are causes and mechanisms that are physical, biochemical, and so on, but they are not included or they are not present in the results that come from the exams that physicians normally ask in their routine examinations. And these conditions do have a lot of stigma around them, also because of this, because there's no obvious cause. But we do know that they are disorders of gut-brain interaction, and that this means that the gut-brain axis is not working as it should. And so that leads to a lot of painful, disruptive symptoms in the GI tract.
Yeah, it's a tough area for people, isn't it? Actually, as you describe it like that, it's a very fluctuating course. It can, an exacerbating course. It can have times of really significant discomfort and pain, which can obviously have a major impact on people's lives. But even when it's not, when the IBD and so on are not necessarily active, it still has an impact on quality of life and functioning and so on. And some of the stigma too, especially with the irritable bowel and things like that, that we, just because we don't fully know what the physiology of it is, for example, doesn't mean that there isn't a physiology of it, but it's actually still, yeah, there's a kind of a stigma there, and people can end up feeling certain self-conscious emotions too about their condition and so on. So you have the real physiological, medical sort of effects and experiences of the condition, plus the psychological and social and those kind of elements as well.
Yeah, exactly. And we do see that in our clinics, and we do see that in our research. Stigma is very prevalent in IBS and IBD, more so in IBS, and possibly
Ah.
because of this context that we are now talking about, right?
Mm.
About not, we don't really know what causes it. And a
Yeah.
lot of times patients are left with questions. What if this is only in my head? What
Mm.
if this means I'm just crazy because the doctor said that I don't have any disorder. I don't have anything abnormal in my exams. There's nothing wrong with me.
Mm.
Because in medicine, and I also understand this because that's also important, but in medicine, there's this focus on making sure that what the patient has is not dangerous. So doesn't lead to major complications that can alter structure or biochemical aspects or death even. So when a physician is sure that everything seems normal in that regard, then it's very easy to be relieved and say, okay, there's nothing wrong with you. Your symptoms are due to stress or so on. So the stigma there is quite present also because of that. But stigma is also associated with other aspects of any disease or disorder, and especially GI conditions due to their embarrassing nature of symptoms, the isolation that comes from having quite complex diseases with complex treatments sometimes, and having diseases or disorders that are fluctuating in time, right, over time. So it's not really possible for other people to know whether this patient can be present in this event next week or next year or
I
next
see.
month.
Yeah.
And so that's another factor associated with stigma in all kinds of illnesses that are relapsing, so that do not follow a very straightforward evolution.
Yeah, there's a couple of things there that stand out. It is an interesting thought that doctors, especially with IBS, they might do all the tests and they might rule out some of the more obvious nasty kind of possibilities. When nothing comes up on the tests, they're actually feeling relieved in a sense. They're sort of relieved. Oh,
Yeah.
okay, it's not cancer, for example, or it's not something like that. So they're, oh, this is good news. But for the actual patient, it's not good news. It's frustrating. It's difficult. We worry about, is this just in my head? And, or do other people think it is? And there's an interesting disconnect there sometimes between the clinician and the patient. But also, yes, the other ramifications socially and in terms of one's routine of life and obligations to meet, or but also fun and play, and it's hard to be in the regular touch football team because you're just not really sure what's going to happen next week with this relapsing condition. So on a few fronts, yes, it's difficult to manage, and it comes along with a lot of suffering. You've really hypothesized, therefore, I think, that self-compassion might be an important part of what we offer people who are dealing with these various conditions. You wrote a paper in 2021, The Prospective Effects of Self-Compassion on Depressive Symptoms, Anxiety and Stress, a study in inflammatory bowel disease. You looked at how self-compassion predicted mental health outcomes over time. Could you maybe walk us through this study a little bit, the rationale and the methodology, and perhaps what you found?
Yeah, so that was the first study on IBD that looked at self-compassion in a longitudinal fashion. And we did find that self-compassion was associated with lower depressive symptoms, anxiety, and stress after 9 months. So our follow-up was only 9 months, but still an association from baseline self-compassion to these psychological distress variables. Yeah, and we did this because we imagine that self-compassion would be important in suffering associated with an illness like IBD, where stigma is so prevalent, and in which shame can also play a role. Because in my PhD, we also looked at how shame mediates, for example, the associations between IBD symptoms and quality of life, social relationship quality, and psychological distress as well. So we looked at how shame is detrimental in those associations. And then we wanted to see, okay, but it makes sense that self-compassion, which we know is quite an important process to help with shame feelings, right? It would make sense that self-compassion would be protective against those outcomes, so against psychological distress.
Mm.
And then we showed that, and that was quite good news, because then we finally have longitudinal findings showing just that self-compassion seems to be a protector in IBD for mental health, and therefore psychological interventions should can focus on self-compassion development, promotion, and hope that this would work, especially in patients with high levels of shame, probably, or self-criticism.
9 months is really quite a decent follow-up. The measures of self-compassion at time one predicted, I guess, depression, anxiety, and stress 9 months later.
Yeah.
For those with IBD. Just a couple of questions. What was the model of self-compassion that you used in this study?
Yeah, it was Neff's model of self-compassion. So we used the self-compassion scale, and we used the scale as a whole. So we didn't divide the scale into subscales. One subscale is compassionate self-responding, and the other subscale is uncompassionate self-responding. So we put those two together in this score of self-compassion, and of course reversing the scores on the negative scale. So uncompassionate self-responding.
Yeah. So you used the SCS and used the total score, and then the depression, anxiety, and stress symptoms. How was that measured at the end?
We did DAS-21, so the depression, anxiety, and stress scales, which is, or maybe was before, more than now, quite used in this sort of research.
Okay, yeah. I feel as if I remember that the paper did unpack different elements of self-compassion, though. And so from the scale, I think the SCS, things like isolation versus and mindfulness maybe seem to relate differently to the different types of outcome. What was the finding there, and what did you make of those differences?
Yeah, we found that the mindfulness component, self-compassion, was especially associated with lower anxiety and stress after 9 months, which was not that surprising, because we do know that mindfulness is associated with less anxiety, less stress levels in general populations as well. And in IBD in particular, it seems that it's quite important to be able to observe thoughts, emotions, symptoms in a non-judgmental way, and that might lead to less anxiety and less perception of stress over time. And then in terms of depression, or depressive symptoms rather, we saw that isolation was the facet that was most associated. And isolation is the opposite of common humanity, right? It's feeling that you're alone in your suffering, that no one understands your suffering, and which is quite a common experience in IBD. So almost any patient will tell you that others don't really understand the illness because it's so complex and it's so outside anything that other people know or have encountered. And the type of suffering is quite unique in that sense. But with this said, an IBD patient is not the only person in the world that is suffering, right? So as we know, we all suffer. We all go through a lot of difficult things in our lives. They're just different in terms of content, in terms of quality, but not in terms of actually experiencing suffering. And this isolation feeling or perception, I think it's quite exacerbated by shame and stigma, because avoidance, as we know, is a behavior of shame. And so people with IBD, for example, will tend to not want to tell others about their symptoms or about their disease. And this is quite common in other diseases as well, like cancer, which can be quite surprising in a way. But I think it's due to this stigmatization of everything that is different, everything that can be perceived as a flaw, as something that is wrong with me, something that is different from what is expected from a functioning human being, right? And so when patients, and this happens a lot, right? When patients do not disclose to others how they are feeling, how they came to this diagnosis, whether even they have this diagnosis. A lot of patients don't even tell their family members or some of their friends that they have IBD or IBS because of the stigma around it and the shame feelings, or being afraid of feeling shame, right? And so that isolation gets even more exacerbated, I think, due to that.
Yeah, when you're describing all of that, it really hits home, even the experience of people who are going through these conditions. But yes, it's interesting. So higher mindfulness predicted lower anxiety and stress, and higher isolation predicted higher depressive symptoms 9 months later. On the mindfulness side, what are you hypothesize, or maybe what's been found around psychological flexibility as also a predictor of mental health outcome? I'm not sure that was in this particular paper, but it just sprang
Yeah.
to mind curiously. But yeah, any thoughts there?
Yeah, sure. No, we didn't look at specific ACT processes in this paper because we know psychological flexibility is the overarching process of ACT, or acceptance and commitment therapy. But in ACT, it's quite interesting. We see that patients, after an ACT intervention, patients actually report more anxiety than at baseline. This is quite common in my studies, for example, and I've seen this in other studies as well, even from other institutions and other countries. So it's quite common. And we think it's because people get more aware of their internal experiences. They get more aware that, yeah, I'm feeling anxiety right now. My heart is racing and so on. And this is because of increased mindfulness, for example, because then they are paying attention to what is actually happening in the present moment in their bodies. But what we do see is that at the follow-up, at 6 months, 9 months, 1 year, then anxiety is much reduced in comparison to post-treatment and also baseline. So at post-treatment, so right after that intervention has been completed, an ACT intervention is finished, anxiety and also other emotions and processes sometimes are increased which can be surprising in a way, but really not so much if we consider this mindfulness influence on our acknowledgement of what's happening in my mind and my body. So I think that can be associated with this, because this result is in a longer follow-up. It's more in the long term at 9 months. And yeah, mindfulness training, because it makes you more aware of your emotions, internal experiences, etc. We have a lot of empirical evidence on this. It leads to long-term higher feelings of calmness, for example, so less anxiety, because then you learn to self-regulate through mindfulness and other associated processes, because mindfulness is associated with other processes, both in the compassion model and also the ACT model. So through all those associated processes and mindfulness, we learn how to cope, how to deal better with symptoms, thoughts, emotions, memories. And I think that is one of the major reasons for this association.
I suppose given this particular paper wasn't an intervention study, it was the person's already established level of mindfulness in their life that predicted less anxiety and stress down the road. Whereas you've made a really fascinating point that in an intervention related circumstance, initially the anxiety or stress might go up, which does make sense, as you say, because anxiety is often associated with a lot of avoidance, trying to not think about thoughts and feelings and all the rest of it, and building that mindfulness competency and means that now we're very aware of our thoughts and feelings and all the rest of it. And so there's an initial bump, which, yes, how people finding ways to persist through that initial exacerbation, and then out the other side, they're able to, the mindfulness really does start to become more and more helpful as time passes. And then the isolation and the sense that the isolation, disconnection, trying to also work there from a self-compassion point of view to help people kind of have that sense of common humanity and shared experience. And that too might help with depressive symptoms down the line as well. You're now leading a study, I think, that's about trying to do an intervention, a randomized controlled trial. It's an online intervention, I think, and combining acceptance and commitment therapy and compassion-based interventions, again, in inflammatory bowel disease. So I think it's a registered protocol at this stage. So what's the plan there with that particular intervention paper?
So yeah, that's the eLife with IBD study, living with intention, fullness, and engagement in IBDs, an ACT and compassion-based intervention to Portuguese IBD patients that we have already completed. So this trial is over. It was done during the pandemic, which was quite complicated, but we don't have the results out yet. But we do have the results from the face-to-face group version of this eLife with IBD intervention, which was just called Life with IBD, so without the E, because it was face-to-face.
Yep.
So as I was saying, these interventions are ACT and compassion based, 8 sessions in total. In the face-to-face group intervention, each session would last about 2 hours. It was led by a therapist, me, for example, and a co-therapist, to a group of around 10 or 12 IBD patients. And then the eLife with IBD version, the online version, is delivered through an online platform that we developed with a software company. And it has 1 extra session. So it's 9 sessions in total. Each goes through 1 or 2 processes of ACT or compassion. So we have 2 explicit compassion sessions in these interventions, and the other ones are ACT-based mostly. And in the online version, each session is completed within 20 minutes or so. And it includes texts, videos with therapists, audios with meditations like mindfulness, compassion, gratitude meditations. And the patients are supposed to complete each session once per week, so one session per week, and complete homework assignments, which normally involve mindfulness or compassion-based meditations. We have the data published from the first trial, the face-to-face trial, but we still don't have the second trial out because we're still analyzing the data. But we do know how the results look like in general. I can share if you'd like.
Yes. I'm
Although
interested actually, I'm interested too in the face-to-face. What were the results there with the face-to-face? Because it's not only face-to-face, but it's also live with a therapist, whereas the online version is online and by the sounds of it, pre-recorded sessions, I suppose. So
yeah.
so how did the face-to-face version go?
So it went quite well until the pandemic started.
Oh, yes. That's what happened.
The pandemic started in Portugal, I think the day before the last session or something like that. So our post-treatment assessment was already within a lockdown taking place in 2020. But yeah, if we look at it in a more scientific way, the same happened with the control group. So we were controlling for that contextual influence anyway. Yeah, so we have the intervention group, the Life with IBD group, and a waiting list control group. And these are pilots. So both trials are pilots because we've developed these interventions based on other interventions that we tested before in other conditions and in ACT and compassion-based interventions in general, of course. We're not inventing anything out of the blue. But yeah, so these are pilots and our ends were not that large, so around 30 patients arm. And we did find, though, that patients with high psychological distress at baseline were the ones that showed the most improvements then at post-treatment. So people that did not really show high psychological distress, depressive symptoms and anxiety, that's what I mean. They reported feeling completely changed after the intervention and even during the intervention. I think a lot of patients start feeling a difference around session 4 or 5. We asked this to them to see which sessions would be most important, but also from which point they start feeling an actual difference. So our acceptability results were amazing, but our quantitative data not as exciting. And this is quite common in this field. It might be the measures that we use or the measures not assessing what patients actually value in terms of patient-reported outcomes or a cultural thing. We don't know. But we did have significant differences with acceptable effect sizes, especially for the people with high psychological distress at baseline, which in a way makes sense because if we're assessing psychological distress as the main outcome and we're using scales for that outcome, if patients don't really have a lot of room to change, right, or to improve, then that outcome might not be the best to have, because these patients that didn't really show that sort of improvement in this outcome, they reported having a completely different outlook about their lives, about other people and their relationships with people, even people around them noticing that they were different, more calm, more focused, happier in a way, not as in everything is good or so on, but in a way that they're not avoiding life anymore. They're not avoiding talking about difficult things like their symptoms anymore. And they're showing more self-care higher self-compassion, and to the point that other people, like their family members, friends, notice that.
Okay.
So these are overall our results. And another interesting finding is that the intervention group improved clinically in the Crohn's disease assessor. So this is an assessor that was fulfilled by the physician, and it was improved in the Crohn's disease patients of the intervention group. We didn't have the same result for the ulcerative colitis patients, but we did have for the Crohn's disease. So there was an improvement in the disease itself in that after the
Okay.
intervention.
It does make sense. It was a small-ish N, although 30 participants in each group, I think it was, is not too bad for a pilot, certainly. And then the question of those who were high in psychological distress versus those who were not so high in psychological distress. So that sort of washes out the change a little bit in the mean scores. But there was everybody felt qualitatively like it was very helpful. They felt the difference and reported that not only feeling different but noticing differences behaviorally in their life, in their relationships, and so on. But those who were higher on psychological distress at the beginning perhaps did show improvements across time. And the actual Crohn's disease symptomatology seemed to improve based on a physician's assessment. So it's very encouraging results, certainly, and seems to point us in a good direction. So that was the face-to-face version. What about the online version of eLife with IBD? So how did the online version of this program go?
We had similar results. So we haven't finalized the analysis yet, but it looks like it's the same kind of findings that we had for the face-to-face. So I guess we had ceiling effects. And so in people that did not have significant levels of psychological distress at baseline, they didn't benefit from this intervention as much as people with high psychological distress as baseline did, which, yeah, it's not
Makes sense.
surprising.
Mm.
But still, we have the same finding in the way that it was highly acceptable and perceived as feasible by the participants in the intervention group. Our control was also an inactive control, a waiting list. So that was quite the same as the face-to-face. And yeah, our results seem to be the same. This online version, I think it would require some refinements in the future. And actually in Sweden now we're building in part on that. And we're creating an online intervention for the GBI with some lessons learned from the eLife with IBD. For example, maybe we shouldn't have a completely self-guided intervention. Maybe we need some contact with a psychologist, with a therapist, at least in the beginning, or even with other patients, because that's an important factor, it seems, of therapy, right? As we can very well imagine as psychologists and therapists. So these self-guided interventions that are completely self-guided, they might be very cost-effective and very tempting to try to test and implement. But maybe, and I'm saying maybe because I haven't tested otherwise, I haven't tested it with this sort of more direct contact with a therapist, but it might be a way of making it more efficacious and even more cost effective.
I suppose the thing that occurs to me is what you said in when we were discussing your earlier paper, the importance of isolation versus common humanity. And for more self-directed interventions, the person remains a little bit isolated. They're still doing it on their own, and it might even feed into that sense of isolation, sitting in their room doing a program, as opposed to, yeah, rocking up to a group and having other like-minded people who are experiencing similar things and that sense of connection with the therapist. It is interesting because the online version produced similar results to the face-to-face version, but you're thinking about the actual sort of interaction with others as potentially being an important adaptation.
Yeah. And that's something that is reported by patients in group interventions. So in their quotes, it's very common to find statements like, it was really nice to meet other IBD patients, to talk to them, because ventilation is also an important factor here in all kind of interventions, especially group interventions, learning by modeling, social support. And so those are very important factors or even mechanisms of the efficacy of a psychosocial or psychotherapy intervention. And that's one of the reasons that now in other trials we're using social support interventions. So a peer group as an active control to the active act or compassion and compassion-based intervention. Because, and I do believe that for some people, those interventions, social support interventions, can be quite efficacious and effective as well. Because acts and compassion interventions might not be for everyone. And in our clinical work, we see that, or at least I see that. Sometimes we really have to change our course of action in terms of the kind of therapy that we are delivering to a certain patient, because for whatever reason, they are not resonating with the ACT model or and so on. So you have to adapt and have a more behavioral approach, for example. And our trials on ACT, CBT, compassion-based interventions, normally what we report is means. So we have group means, and we know that there's a lot of people that are above or below as outliers, and that either don't benefit as much or don't benefit at all, or might even get worse. And so we do have those cases. And yeah, with this, I would like to say that I don't believe that these interventions we're testing are for everyone, or that they would work for everyone with IBD or IBS. And one of the key aspects of my research right now is to try to find what works best for whom and when, because that's another question. A lot of people say, oh, I wished I had come across this approach or this intervention when I was diagnosed. This is very common to hear across disorders and diseases. And that's one of the obstacles we have.
Yeah.
In our
Yeah, no,
trials.
it is the next big interesting question, isn't it? Is the processes of change, and is it working with experiential avoidance or cognitive fusion or cultivating mindfulness or common humanity, or like what are the bits that work for different people at different times? And early intervention is an interesting further kind of angle as well. I can imagine with groups and live groups where people are together, the other benefit there might be that it allows people to practice the flows of compassion in real time, because they're not only supporting each other, but they're feeling that support coming back, and along the way developing the self-compassion. So the three flows can be really activated in more of a group setting. So it is interesting to think about the different processes behind change for any given particular individual.
Exactly. And we can have that sort of mechanism that you are referring to, even in a social support.
Yeah.
And we're working on a paper right now in cancer where we're identifying that, not in terms of self-report scales, but in terms of the statements that patients tell us or even write to us after the treatment has been completed. They do talk a lot about finding support in other patients and learning from them, ventilation again, as I was saying before. So all those aspects, we should not at all ignore them, especially when we're talking about compassion, because they are training compassion towards other people and also receiving compassion from others and self-compassion, even if there's no explicit component of compassion in that intervention. So it's interesting to think about, I think.
It is,
And to
yeah.
go in there a bit, yeah.
I'm really appreciating that thought actually, because I'm often coming from a CFT point of view, and so then we think about the CFT psychoeducation and what is compassion and exploring some of the evolutionary stuff and all that sort of thing. Whereas it might also be really powerful just to bring compassion in real time through a support group where the compassion starts to flow, perhaps facilitated by the group therapist and so on. It's actually potentially quite powerful to experience those things in real time. The other bit that is really important, and I guess you started with this in our conversation today, is the role of stigma and shame. And you've just had a paper accepted, I think, in gastroenterology, implications of shame for patient-reported outcomes in bowel disorders of gut-brain interaction. You did mention at the start that something like IBS is that bit more susceptible to stigma and shame in a sense. So I guess this is a really important topic as well. Shame seems to be a major mediating or moderating factor in psychological well-being. So tell us a little bit about this next study that's coming out.
This study was in Gothenburg, so these are Swedish individuals meeting criteria for a bowel DGBI, like IBS,
Okay.
for example, or functional constipation, functional bloating, and so on. The idea behind was because shame was completely unaddressed in research in this population. So I had done some studies in IBD, and there are quite a lot of studies on stigma in these populations, especially in IBS, because it's so prevalent and so impactful on the person's life. But there was no mention of shame even in those stigma papers. And I wouldn't really observe any conversations among physicians or other healthcare professionals about shame, only stigma, but not really how that impacts the patient in terms of emotional experience and impact. And then I started reading about it, and some authors even consider shame as the elephant in the room in medicine. So it's there, and everyone understands it's there, but no one really addresses it. And we know in theory, and not only theory, right, in this field, that shame drives avoidance and is associated with quite negative experiences and adverse outcomes, both psychological but also physical, because if you're ashamed of telling something to your physician, then that might put you in trouble in the long term. You might not get the treatment that you need in time, at least. And that's just an example. So yeah, I would see a lot of research about what causes IBS symptoms, for example, and not so much about what does IBS cause other than psychological distress and lower quality of life. So because we did know and do know that there's this cycle between GI symptoms and psychological distress because of the gut-brain axis, for example. That's one of the mechanisms. But not so much about, but what about what patients feel when they are experiencing these poop-related symptoms in which that are so associated with taboo. So there's in a lot of cultures in the West, at least, poop-related issues or conversations are a target of stigma and taboo. Like you cannot talk about having diarrhea, having constipation, farting, being bloated, even. And that's, quite associated with feelings of being different, of being an embarrassing person, unattractive, when you experience these symptoms very often and in a very intense fashion, which is the case to a lot of patients that suffer from IBS and other bowel disorders. So that was the idea, to try to see, if there's an association between IBS symptoms or bowel symptoms, since this is a more general bowel DGBI sample of around 500 Swedish individuals. and then whether shame can explain that effect from IBS symptoms or bowel symptoms towards psychological distress and then quality of life. And we did have a very, very good model, so it fit really well to data. And shame completely removed the effect of GI-specific anxiety from the model. GI-specific anxiety is considered to be one of the major factors in IBS that is associated with psychological distress, for example, in this population. But then when we put shame in the model, GI specific anxiety did not even have an association anymore with psychological distress or quality of life. And that shows that shame is so important in this sample, or at least more than what the most important factor so far in this context is.
Yeah, it was really striking when you were talking about stigma and taboo, and then said poop and diarrhea and constipation and farting. And I noticed even in myself, it is, but I really can see that a clinician or a therapist and so on who can feel really comfortable in those discussions can help to potentially reduce some of that stigma and start to just maybe soften a little bit the shame that comes out of that. And it's such a funny human thing that we have these taboos, and it causes us all sorts of difficulties, really.
Yeah, I actually don't know why that is the case. Maybe associated with disgust or infectious diseases. I have no idea what is the cause for this sort of taboo, because I think I'm not completely sure, but I think there are studies that show that talking about poop, diarrhea, and so on is more of a taboo than talking about sex, for example.
Yeah.
That's an interesting finding.
It is, and it does mean that people with these sorts of conditions, through no fault of their own, and they're struggling along with them, but suffering in silence a bit, and they're left with these very painful feelings of shame that overwhelms even the GI anxiety effect, that the shame is burning away there and having this really profound effect on the person's outcome. Just a quick clarification, the words stigma and shame, because you're absolutely not using them interchangeably there. So what are the actual real definitions there of stigma and versus shame?
Stigma is an attitude, and it can be perceived. So if I think that society in general or other people have this sort of stigmatizing view on my disease, for example, then I'm perceiving stigma from others. But it can also be internalized, and that's normally a bit more problematic and lead to higher levels of shame, which is an emotion. It's a complex emotion, self-conscious, painful, completely normal and adaptive. And that is actually something important to highlight. And I did write this in the discussion of the paper that you're mentioning. Completely adaptive. We need shame. We need all emotions that we feel. And that's why we feel them. But shame in very high levels can be very painful and lead to avoidance and among other behaviors and attitudes. Yeah.
Given those findings then of this paper, what do you think are some of the key ways clinicians, doctors, therapists, and so on can respond or intervene with shame in a more, I guess, compassionate, but also just helpful, effective kind of way?
Yeah, that's quite a good question. And that's what physicians are thinking right now, if they are listening, right? What can I do? It's not easy. It's not easy to deal with this. And I think now I do know that in medical training, this is not prioritized. But being compassionate in our communication and interactions with patients should not be seen as a luxury. It should be seen as part of evidence-based medicine, because we have the evidence that being compassionate towards patients leads to better outcomes, improves adherence to treatment, and it also is associated with better outcomes in the physician themselves. And so my advice would be to not being so much on the doing mode. And this is a bit associated with mindfulness as well. And that's why mindfulness is a component of compassion. So being more present instead of just doing, also being. And that involves being with your feelings and using your feelings and your more human experience. Also, as a physician or as a healthcare professional, we don't have to throw that away from the window, right? But even as a physician, we are, or psychologist or a nurse and so on, we are healthcare professionals. We are here to care. And that part, I think, we forget when we're considering non-technical, more doing mode associate jobs or work that we do with the patient. And so just trying to look at the patient as a person. And studies show that is associated. If the patient understands that the healthcare professional sees them as a person with a life, with loved ones, with people they love back, with a job, with goals, with values, and so on, that leads to better outcomes. And that helps with compassion as well, a lot, because then I can empathize, first of all, better. I can be more sensitive to this person's suffering. And I can show that through my body language. And that's another key point, I think, because in our psychology training as psychologists, we learn that almost all kinds of communication are key a lot of times and can even be part of the therapy itself, right? Whether we're looking at the patient or not, our tone of voice, our body movements, how we're sitting in the chairs and so on, right? So it's not just about the words. So it's not just about the doing. It's also about how we're doing and whether we are actually paying attention to how we are feeling and whether we're using our body as well. And noticing how we're feeling in our bodies can give us a lot of clues about what to do next. Because if we're not feeling very all right, because this patient is telling me quite a difficult story or symptoms or so on, and if I'm feeling sad, for example, or anxious about how this patient is going to improve or not, so that is a signal that, yeah, if I'm feeling like this, then this might be even worse for the patient. So trying to use that to connect and show that you're connecting with the patient and you're understanding their point of view. Or even just thinking for 3 minutes, how would you feel and how would your life be if you have IBS as well, or IBD? Just imagine the pain you'd feel almost every day, having to go to the toilet 10, 20 times every day, how that would impact your work, your relationships, your family, your friendships. How would that be? And that is a reminder that you are also human, just as your patient. You have the same kind of body, the same kind of mind. So you would probably react the same way as this patient is reacting. So that's sort of common humanity as well from the physician, that we're in all this together, just with different kinds of problems and suffering, but still suffering and still exposed to the same possibility of getting sick and quite ill from something, and also experiencing all the emotional consequences of that, like higher shame feelings and then behaviors to try to help with that. And also, this is another important point, because it's important to understand that shame is an adaptive emotion, and it's only natural that patients with these conditions feel it at such high levels. And it's not just about the symptoms, it's also about treatment itself, or what patients feel should be treatment, because a lot of patients avoid food in a chronic way, and that's not very recommended. And that's one of the reasons we should have dietitians treating these patients together with physicians and other healthcare professionals, as we know, psychologists, social workers, pharmacists, so on. But for a lot of patients, even going to a restaurant or eating in front of other people, that can be triggering in terms of anxiety and shame, because then you're not eating the same as other people, or you're not eating at all, or you're going to have symptoms right after, so you have to run to the toilet, or you're going to feel pain and other people will notice. So this is quite associated with feelings of being inadequate, inappropriate, different, and we know that is associated with shame feelings. So trying to see the patient as a person, and I know that it's very easy to say, but and to not consider only being compassionate as part of the art of medicine, but also part of the science of medicine, because we know that it is part of the science of medicine to have this sort of connection, interaction, communication with our patients.
Yeah.
Also, I should say something else, because we know that there's a lot of barriers to this, and one of them is the time, and we face this issue in our healthcare, and I think this is the case in almost every country, or at least the ones I know. There's not a lot of time for a physician or a nurse or other healthcare professional to invest with the patient, and so there's not a lot of time to get to actually know this person. But even if we just have 5 minutes or 10 minutes in our appointment with the patient, those are still minutes where there are a lot of interactions taking place. And those interactions mean something to the patient. They can be compassionate and empathetic or not. They can show care for the person and not just this patient with this IBS that is so difficult to treat. I have no idea what to do with the patient. Or they can mean, yeah, this doctor actually cares about me and is in this with me together and cares. And that we know by evidence that changes a lot to the patient and to the healthcare professional.
Yes, it's the lyrics and the music, isn't it? Together.
That's a good metaphor. Yes,
Yes,
exactly.
it's what the clinician might do or say or suggest or recommend, but it also how we frame that in a kind of a spirit of compassion and care in the interaction, the tone and the feeling as much as perhaps the information. And I can imagine that lots of clinicians and doctors, all the rest, they feel a little bit of anxiety too. And they feel sometimes clinician shame almost. How do I help this person? And they want to help and they're not sure what to do. And then they resort to trying to tell them things or trying to do things. And sometimes that can mean we move a little bit away from the warmth and the safeness, the empathy and the sympathy and the listening and helping the person feel just really heard and understood and feel safe in that conversation. And in some ways, your recommendation there is, yeah, just to think about how might we warm it up a bit in a compassionate way when we're having those interactions, because your research has shown that shame is a key part of it, and self-compassion and compassion, I suppose, can really help. And so even those kind of sometimes brief clinical interactions can be something of a seed to plant that compassionate feeling between us, but also within the person. You mentioned barriers like time. The other barrier I was thinking about too, from some of your old colleagues at Coimbra and your work, I think, as well, but shame can make it really hard to receive compassion. And
Yeah.
so that's sometimes something that clinicians are working with as well. Like, I'm trying to be compassionate and they're not taking it in, sort of thing. But that's part of it. That's part of the persistence and the sort of the gradual, almost exposure, habituation for the client to gradually feel safe enough to let that compassion in. But it, yeah, just you've really today highlighted just that really important thread of compassion and how helpful it can be.
Yeah. And yes, of course, yeah, physicians also struggle, yeah, as you were saying, and I can understand that it can be very frustrating to not know what to do with a patient, or to see a patient that you care about not improve as much or getting worse even over time. And that's quite common, especially in IBS, because it's such a difficult condition to treat in some cases. So yeah, it's also important to be able to sit with it and be self-compassionate as a
So
physician.
compassionate for the physician.
As well,
Yeah.
right? We're not to blame that we don't have good medications for some patients. We're physicians, we're not scientists, and even scientists are not to blame either, because this is a process and these are quite recent types of research. It's not that these disorders like IBS have only very recently been started to be studied in terms of treatment, because before all the research would focus more on IBD, because that was considered a real disease.
I see.
And there's also not a lot of funding for research in the GBI. And so our scientists, physicians, it's also important to remember we are not to blame. All right. And it's normal to feel shame. It's more important about what do we do with that shame. Are we going to avoid going there, or are we going to face it and say, yeah, I'm feeling inadequate. I'm feeling like I failed, or I'm feeling like I'm not being able to connect with this patient. What can I do? What does my body tell me to do? Yeah. So it's also important to be attentive to that. So your own feelings and your own lived experience as a healthcare professional dealing with such difficult conditions over time.
You certainly embody all of these traits. You're just such a so that on the intellect scale, I have always long admired just the way that you're able to think through these things and create really sophisticated research papers to try to work this stuff out. But you bring a lot of heart to it, and the papers are beautifully written, and just the way that you describe it all today, I can sense the real genuine empathy that you feel for the participants that you're working with. And just courage is the other piece, just being willing and able to go there and to work in these difficult but really important areas. So thank you for all that you do and all that you've created and generated, and in these important areas. But also, Inês Trindade, thank you very much for speaking with me on Compassion in a T-shirt.
Thank you, Stan. It's been a pleasure. And thank you for this podcast. It's a great initiative. And I've been listening to some of other episodes, and it's such good communication of science and also clinical work. So it's really a very good public service, I think. So thank you. And
Thank you very
congrats
much.
for this initiative.
Thank you.
Thank you.